I'd like to welcome you to the webinar, The HPV Vaccine, a Missed Opportunity for Cancer Prevention. Our presenter today is Dr. Kevin Ault, who is an obstetrician-gynecologist at the University of Kansas Hospital and a professor of obstetrics and gynecology at the University of Kansas School of Medicine. His clinical and research interests are infections and women's health, and I am going to now mute myself and turn it over to Dr. Ault, who will begin the webinar.
Good morning, everybody. This is Kevin Ault, and I'm in Kansas City, where we're having a beautiful spring day. I hope the same is true across the Midwest, wherever you happen to be. So I am a gynecologist here at the University of Kansas. A lot of what I'm going to be talking about is actually research I was involved with as far as the safety and efficacy of this vaccine. This research was done when I was at the University of Iowa. I was there from 1996 to 2005. More importantly, both of my children were born at the University of Iowa Hospital, and so I certainly have fond memories of those years. My daughters consider Coralville, Iowa to be their hometown. So if you're listening in Iowa, so a little shout out to you. So I do not have any conflicts of interest with this talk. The clinical recommendations that I'm going to emphasize are really consistent with what the Advisory Committee on Immunization Practices recommends. However, you may be listening to this because that's likely to change in the very near future as far as the age range of this vaccine. I also recently became a voting member of the Advisory Committee on Immunization Practices, so I do act as an advisor. That's a committee of the CDC, the Centers for Disease Control and Prevention in Atlanta. So, and I have a somewhat similar function with the American College of Obstetricians and Gynecologists, as well as the National Cancer Institute. Specific to the topic we're talking about today, but really I'm talking for myself today. I'm not doing anything official on behalf of any of those groups today. So one of the things that I really enjoy when I'm not thinking about medicine and science is American history. My daughters that were born there in Iowa are both college age now, and they both got me books the past couple of holidays about Senator Kennedy. Some of you probably saw last year was the 50th anniversary of his death, and in my family we have some fond memories of Senator Bobby Kennedy because he was campaigning for president in the spring of 1968, and several of my family relatives got to see him. But the very first campaign event he went to in 1968 was at Kansas State University. And almost 50 years to the day, I gave this talk at their cancer center, the Johnson Cancer Center at Kansas State. And so I was reading this book at the same time I was going to give the talk at K-State. And so one of the quotes from Senator Kennedy for that talk was, "Tragedy is a tool for the living to gain wisdom, not a guide by which to live." And that really resonated with me. Of course, Senator Kennedy was talking about the Vietnam War at the time, but I was thinking about my talk and how we're missing a generation of young men and women, basically my children's age, that are not getting cancer protection. And there are going to be tens of thousands of excess cases of cancer in that generation. And so we really need to talk about, I'm going to spend a lot of time at the end of this talk talking about, how do we up our vaccine rates? So this other quote from Senator Kennedy is not so serious. About 1/5 of people are against everything all the time. So most vaccines get up to about 80% acceptance rates, some a little higher if they're mandated for school and that type of thing. So, he said that, I'm sure, with a little tongue in cheek, but we're not going to get to 100%, but we can certainly get above the rates that we have going on right now. So if some of you have heard me talk before, you may have seen this slide because I've had this in my slide deck for quite a while. So, the point of this slide is that about 1 out of every 6 cancers on planet Earth is due to an infection. So Helicobacter pylori is gastric cancer. HPV is the cervix. I'm a gynecologist, so I have cervix, et cetera, there. Really, to be fair, and I'm going to show you a lot of this data, the most common HPV-related cancer in the United States now is head and neck cancer in men, not cervical cancer in women. And that epidemiological shift has just happened in the last few years. So, so that's where the epidemiology is headed. Of course, in the developing world, there are 500 million women in India, there are 500 million women in China that don't have access to cervical cancer screening, and so in those countries, cervical cancer would certainly be the most common causes, the most common HPV-related cancers. Viral hepatitis, hepatitis B and C are certainly causes of hepatic cancer the world over, including the United States, for that matter. Of course, we have a vaccine against hepatitis B. Unfortunately, many of the people that are my children's age got vaccinated for that when they were younger, and I would guess many of you have been vaccinated for that as well. You may have seen this slide as well if you've ever heard me talk before. I always show these slides to the medical students. I say, all you got to do is find a link between an infection and a cancer and you win a Nobel Prize. So everybody on that previous slide that discovered those links has won a Nobel Prize, including Dr. Zurhausen, who works at the German equivalent of the National Cancer Institute in Germany. And so he won the Nobel Prize in 2008 for his discovery linking cervical cancer to HPV. If any of you saw or read the book, The Emperor of All Maladies, there's a little bit of that story in that book. There's also a Ken Burns PBS special. If you want to watch it, it's really interesting because some of the people that were young and ambitious in the 80s and 90s are now senior people at the NCI, so it's kind of fun to hear them come up to the ranks. But some of you may remember we thought it was herpes back in the 80s, and Dr. Zurhausen proved everybody wrong and subsequently won a Nobel Prize for that discovery. This is actually from his paper. I think it's, 1983 is when this paper is. And again, this is a low-tech discovery, and this is from the Nobel Prize website, and they also have an active Twitter feed if any of you are on social media. But basically, he ground up cervical cancers and found HPV DNA, and you can see this little radioactive probe here to label for HPV 16 was the one he discovered originally, and then he went on to discover several other HPV types that are associated with cancer. And so he very deservingly won the Nobel Prize and shared it with the two French scientists who discovered the HIV virus. So that particular year, 11 years ago, was a day for the virus researchers. So let's turn the clock forward to 2019. So there are multiple new developments going on as far as the HPV vaccine, and really it reflects what's been going on in the past 12 years or so since the vaccine has been approved and more widely used. There's an increased emphasis, and I gave this away already, on head and neck cancers in men, and as I said previously a few slides ago, it is the most common HPV-related cancer. There's really maturing, I guess for lack of a better word, data concerning efficacy and safety. I'm going to show you a study that was done in Scandinavia here in a few slides. That's 10 years follow-up, 10 to 12 years follow-up on the HPV vaccine, and it looks magnificent. There's also the only bold type I use in this whole slide presentation, 37 slides today, is a Finnish study that shows that women who were in the original trials are not getting cancer. So that, the news is good. There have also been some enormous safety studies done, and I will talk about that. That's something that patients are going to ask you about frequently. Because of the poor uptake of this vaccine in the United States, there's been an interest in best practices to give advice about how to increase the uptake of this vaccine, and there's been enough research, we can really summarize that, and then I'm going to kind of finish up the talk with the pros and cons of expanding the age range for men and women to get this vaccine up to age 45. So again, this is another older slide in my collection, but I still love this slide. So Dr. Bonnet, who's one of the original researchers in the HPV vaccine world, gave me this slide years ago, and I've kept it because it's such a nice illustration. So, and what it illustrates here are the sites that are vulnerable to HPV-related diseases, including cancer. So the little red dots here are the high-risk HPV types that are associated with cancer, and they tend to cause problems in 3 distinct areas. So the head and neck region, the tonsils and the oropharyngeal cavity, the cervix, and anal cancers as well, anal dysplasia and anal cancers. There are less numbers of penile cancers, vulvar cancers. This particular diagram here has male and female genitalia. Vaginal cancers are rare, but are also HPV related. So there's some other cancers, I'm not going to have a chance to talk about this, that are non-melanoma skin cancers that may be associated with HPV types 5 and 8. They're not really GYN pathogens, but if any of you are aspiring to get a Nobel Prize, that's probably the next Nobel Prize for infections and cancer out there. So, but you know, the real thing I want to emphasize are these 3 cancers are the most common HPV related cancers. The little pink circles are the low risk HPV, and I'm going to show you this on the next slide. But basically, HPV 6 and 11 are the types that cause genital warts, and so those are the low risk types. Again, if you have children, you probably know there are cutaneous warts you can get on your hands and your feet, and those are HPV 1 and 2 respectively, if I'm remembering correctly. And so this is kind of expanded. 4 or 5 years ago, the CDC came out with a slide deck that if you ever get asked to give this talk, you can certainly use that slide deck. I think a few of these slides have actually stolen from that slide deck that kind of emphasize some of the basics, then go into some of the research. So, but mucosal sites of infection, those are really the types that I emphasized on the other slides. So 16 and 18 are the most common, are associated with these cancers, and then 6 and 11 are the low risk types that do not cause cancer, but certainly cause clinical problems. If any of you have ever had a child or an adult that has laryngeal papillomatosis, you know that that's a very severe disease. That was actually in the Washington Post a few days ago. If you've never heard of that disease before, it's worth a read of that article. There are only a few thousand cases of those a year, but it's very devastating. Much more common are these cancers. There's about 43,000 HPV-related cancers in the United States every year. And as I said, the oropharyngeal cancers are now the most common. Most of the ones on this list here, and I may have a slide later that says the same thing, are due to 16 and 18, or I'm sorry, due to 16. But cervical cancer has a little more variety. So there are about 6 or 8 types that are associated with cervical cancer. And basically there's a HPV 16 family and an HPV 18 family, and they cause cervical cancer. And most of these other anatomical sites are HPV 16. We're lucky that all versions of the vaccine, the first and second generation versions, all protect against HPV 16 and 18 for that matter. And so we'll talk about that when we get into a little more of the nitty gritty of the vaccine. And then there's lots of data along this line as far as prevalence data. I just picked this slide out because it's done by Lori Markowitz. Some of you may know her. She is a physician at the CDC who has, for a decade, very ably led the HPV vaccine efforts at the CDC. So if you ever get a chance to hear her talk, she's a very good speaker. She also has published a lot of research in this area. So, but this is a fairly recent publication that came from the Journal of Infectious Diseases, and these are data that show the prevalence of HPV, and I think these are the 4 types in the original quadrivalent vaccine, and so you can see that in the earlier time frame, the vaccine types were a little more prevalent in the younger age groups, but the good news is that was the group that was targeted, and the prevalence has gone down, particularly in this youngest age group, so that makes us all feel good that our vaccine recommendations are working. So, but not much of an effect here in the older age group. Of course, as time marches on across this age continuum, we'll have effects in that older age group. So, I am in a recording studio in the basement. It's a brand new building at KU, but it's in the basement, and somebody is knocking on my door. I think I forgot to put my do not disturb sign out. So give me 2 seconds to turn my sign on to see why somebody's knocking at my door. Okay, the technician just wanted to know if everything was going fine, so I hope everything is going fine. So this next slide summarizes the current ACIP recommendations, and so several things changed kind of at the end of the calendar year of 2015 and the beginning of the 2016 calendar year. This is a multi-page document, so if you want to read the whole thing, you need to click on this link down here, but it may change again in 2019, but I'll give you a brief summary here. So routine vaccination of adolescent males and females ages 11 to 12 with 2 doses of HPV vaccine. That was a sea change. I'm sure we have some people that practice pediatrics or see pediatric patients in on this call. So you can really do 2 vaccines a year apart and have the same immune response as the older 3 vaccine series, as long as you start before age 15 is really what the data shows. So you can start as young as age 9. Some of the states in our listening area, including Kansas, have a adolescent pertussis virus requirement to go to 7th grade, if I remember correctly. My children are older than that now. So, there's a whole series of vaccines that children get in the 11 to 12-year-old age range, including meningococcal vaccine, pertussis boosters, and the HPV vaccine and the flu vaccine. So there's a whole adolescent platform. If you're over age 15 at initiation of the vaccine series, you get 3 doses over 6 months. The current catch-up is to age 26. There's some subtleties between the male recommendations and the female recommendations. And again, being a gynecologist, I tend to be kind of female-centric. So the subtleties are really on the male side. So the current version is 9-valent. I'm going to talk a little bit about that over the next few slides here, what exactly that means. And so we're kind of into the 2nd generation of HPV vaccines. That's the last 3 or 4 years with the 9-valent vaccine. And again, this is a slide from the CDC. So I'm going to do the animation here so you can kind of see what the people at the CDC had in mind. So, and I've said this before, but the quadrivalent and the 9-valent vaccine, which is the Merck product, both have HPV 16 and 18 in them. So the 9-valent replaced the quadrivalent vaccine. You can see, I usually say 70% of cervical cancers, but certainly a majority of cervical cancers are caused by 16 to 18. All generations of the vaccine have had the protection against those 2 types. The bivalent vaccine is made by GSK, is not really marketed in the United States, so overwhelming majority of the vaccine given out in the United States is really currently is the 9-valent vaccine, and historically has been the quadrivalent vaccine. And then you can see you get a little extra bonus, and the next slide kind of emphasizes this, of these other types. So if I remember correctly, 31, 33 are cousins to 16, and 45 and 58 I think are cousins to 18. But in any case, it just emphasizes what I said a few slides back, that there's a little more variety for cervical cancer, and we get better protection with this 9-valent vaccine, and my next slide kind of emphasizes that too. So this is a international study that was done before the 9-valent vaccine was available, but it shows the proportion of cancers due internationally. This is multiple countries. And if I remember correctly, European countries involved in this. And so, as I said on that previous slide, 16 and 18, you get up to about 70%. And then you start putting in these extra types to get up to the 9-valent. You can see this varies from about 2 to 4% when you look at an individual country. And I'm not going to go through this data in a lot of detail, but you can get up to almost 90% of primary prevention of cervical cancer with the 9-valent vaccine by adding the extra 5 types that are in this new generation that's been available for 3 or 4 years. So, so good news overall, especially for women's health as far as preventing cervical cancer. If we showed high-grade precancerous, and I have some data along this lines in a few slides, So that has a lot of names, unfortunately. So high-grade cervical dysplasia, cervical interepithelia, neoplasia. I think we've thought of all these names to confuse both providers and patients. So, but the higher grade lesions are going to reflect this. So we're really talking about decreased surgeries for cervical dysplasia, decreased abnormal pap smears. And so really, when you look at the cost effectiveness of this vaccine, it's really primary prevention of abnormal pap smears, of cervical procedures, of cervical cancer. And so, and we spend about 3/4 of our healthcare dollars of HPV spending on the precancer of the cervix. So as I said, this vaccine has been around for 10 years or so, maybe even a little longer. So there are just beginning to be the first data available showing protection against cancer. There's an American study that was published after the Finnish study. So I haven't updated these slides with the American study yet, but I will eventually. So there have been some huge systematic reviews as well as individual data concerning the 9-valent vaccine, or initial data, I'm sorry, with the 9-valent vaccine. There were about 7 trials, if I remember correctly, done in pediatric age populations looking at safety. So we're up over 100 safety trials, which is a good number to remember for the HPV vaccine, and they have all been very consistent that the vaccine is safe and effective. So the uptake of the vaccine, as I said, has been an issue in the United States, and I have some state-by-state data here in a few slides before we jump into techniques that will increase vaccine uptake in your area. So, but really it boils down to provider recommendations, and how those recommendations are made is the preview of that topic. So, but let's do efficacy and safety first before we get to uptake. So this is a slide. These data are actually a few years old. So, but this graphic is still really good. I actually saw this graphic on Twitter a few days ago, so I know that people are still using it. So one of the inventors of the HPV vaccine, Ian Fraser, is Australian, Scottish by birth, has spent his entire medical career in Australia. A great guy, again, if you ever get a chance to hear him talk. And so they knew that they were going to be some of the first countries to give the HPV vaccine. And so they very carefully monitored things as far as clinical outcomes. And so this very first slide is genital warts. And so the targeted population, similar to the United States, they have very similar vaccine recommendations, are the younger group. And so that's kind of that darker green line. And you can see 2007, when the vaccine became available, they had a precipitous fall in the number of genital warts diagnoses in women. Similar to the United States, they started giving the vaccine in 2007 to women, and then in 2011 to men. Genital warts in HPV, or in men, also went down because of herd immunity. Heterosexual men were having intercourse with HPV vaccinated women, so their risk of acquiring genital warts was less, and eventually they started vaccinating men. And then you can see again, as women age into this older cohort, which is the red dashed line, it goes down. There's actually more data out here. You can see this is actually a few years old, and for men. But basically, you know, the Australians are kind of famous for this and have published a lot. If you go to an international HPV meeting, the Australians will stand up and say, you know, we never see genital warts anymore in our clinical practice. And when, you know, somebody schedules a patient to be seen for genital warts, we know it's an American college student spending time in Australia. We know it's none of our own children. So they get the knife in there and they twist it a little bit for the Americans in the audience. And so Australia has basically eliminated genital warts as a clinical diagnosis because there are high vaccine uptake, and there are consistent efforts to get it to that generation that was most at risk. And then this is actually from a website. Some of you may know that Canada and Australia have these large provinces that are how they do healthcare. And so these are the, and they have a centralized cytopathology lab in Victoria, which I think is the south central state of Australia. But you can look at their annual report, and this was from a couple of years ago, about their rates of abnormal cytology. And in particular, this is their trends in high-grade cervical abnormalities. And again, you can see the targeted age group, the 20 to 24-year-olds are kind of, again, a light green line, and they just hit the floor. And then the yellow are the under 20 group, and then you can see the 25 to 29 following. Again, they started in 2007. So you don't even have to know which lines to look at. You can just see 3 of the lines are going down. And even the 30 to 34 group starts to go down here at the end because people that are vaccinated back here are now getting up to age 30. So the news is all good, and the Australians have done an excellent job as far as informing us about this. But there's lots of Danish data. There's just tons of data. So I just wanted to go over 2 good dramatic examples. So as we've gone into the future, we've kind of started to see data like this, and this is actually American data. So these are young adults who were either vaccinated or unvaccinated, and unlike the previous slides, this actually includes some male data. So I think this slide can be a little confusing in a way, and I'll point out why, but this is, again, that NHANES data that I showed you from Larry Markowitz, but rather looking at the cervix, this is oral HPV prevalence. And as you can see in men, and this is a relatively consistent finding, in about 2% of men, you can find one of the HPV types that was in the original quadrivalent vaccine. In the vaccinated men, it's 0, so there's not really even a bar here. So, but you can see in women, about 1% in this cross-sectional study carry the HPV virus in their head and neck regions. This is actually just a swish and spit kind of study, so it's not any directed swab, although that's a very good way to do studies, it's turned out. So, and in the vaccinated women, again, there appears to be protection against carriage of HPV types, again, mostly 16, that's associated with head and neck cancers. And so there have been a few studies like this. There's not as much data on the head and neck. I always say that our cancer center director here is a radiation oncologist with a special interest head and neck cancer, and we do panels together all the time here locally. And I always say gynecologists got about a 30-year head start on the head and neck surgeons. So, so a lot of this data is being worked out. So, but what we know, I think, is similar to this slide. And this researcher is at the National Cancer Institute, the American National Cancer Institute, if you ever get a chance to hear him talk. And so when we look at efficacy, and again, most of this is female data from the cervix, when we look at efficacy, we have all these studies, and Dr. Garland has summarized them for us. So this is the Australians have summarized data from 9 different countries with 58 studies, and show efficacy against initial HPV infection, genital warts, precancers or dysplastic changes, so precancer of the cervix. So, so that's all good news. Whatever endpoint you choose to study, you can find data that it prevents these baseline diseases. As the data has matured after 10 years, we're beginning to see some signs that high-grade cervical dysplasia is prevented as well as cancer. And so this is actually a Danish-Swedish study, but this particular researcher is Danish, so I have Danish up here, showed 90% efficacy against precancerous lesions over 10 years. They looked at women who got the HPV vaccine in their early teens, and then they're about the same number of people in Denmark as there is in Iowa, and they have a centralized pathology lab, and they can follow people forward. And they found 90% effectiveness against precancerous cervical disease over 10 to 12 years. They really had a little longer follow-up than I'm giving them credit for. And then the Finns have been following people who were enrolled in the original vaccine trial. So this is more like 15 years of follow-up. And again, Finland's a country of about 3 or 4 million, and they have a central cancer registry similar to what we do in the United States, but on a much smaller scale. And they have tracked the women who were in the original HPV vaccine trials, 15 years ago, some of the same trials that I participated at the University of Iowa. So, and they have found 0 HPV-related cancers at all anatomical sites. So no cervical cancer in those women, no head and neck cancers, no anal cancers, and it's a statistically significant difference. It was published as a letter in International Cancer Journal at the end of 2017 in December. There'll be more publications from this. Hopefully this will be the lead story on the evening news when these data are finalized. And then I'm going to emphasize a little bit more about the head and neck cancers in men here. And the thing to emphasize is the slope here. So, and this data actually goes back well into the previous century, but you can see this marked increase in the rate of HPV positive head and neck cancers in males, and a little bit of an increase in women, but not quite. So 1988 was actually the year that I finished medical school, and so I was taught in medical school that head and neck cancers were the veterans at our big VA hospital in Indianapolis, where I went to medical school, who smoked and drank. So this epidemiology is different. These people are not smokers or drinkers. They are younger, healthier, and they have HPV positive tumors, where these older tumors were probably HPV negative, although they had a similar histology. And so there have been a couple of studies. There is a study that was in the MMWR last August that got a little more press than this study did, but this is the rate of, this is a logarithmic scale, and this, you can see the little empty circles are cervical cancer drifting down, but oropharyngeal cancer in men is red in both these upper graphs, and so you can see it's going up. So sometime in the last few years, these two have switched, and so I actually need to save this, change this date, because it's not 2030 anymore, it's more like right now. So, and a majority of these cancers happen in men. So again, I think that data is on this left-hand panel. So, so we've already reached this plateau that was predicted a few years ago. And I made this point on a previous slide, but I'll just emphasize it a little bit more because you'll get asked about it. So there's higher oral prevalence in men than in women in almost every data set that you look at. So this is all types of HPV, so this is a little different than the previous slide. And you can see that comparing men to women, men are the red and women are the blue, that there's an increased rate of HPV 16 as well as all types in men. We don't know the reason for that, and it would be nice to figure that out. We also do not have a pap smear equivalent for head and neck cancer, so you cannot send anybody out to a local commercial lab and have them tested, have men tested for HPV in that area of the body. And so that's a very active area of research. And so both the epidemiology and the basic science need to be worked out to find a secondary prevention for this cancer. So again, trying to make it analogous to the pap smear. And so this is kind of a silly slide that I usually throw in. When I left Iowa, I went to Georgia. There are 6 law schools, I think, in Georgia. And if you correlate, this is from a website called Spurious Correlations, so you know it's a silly slide. So if you correlate the number of lawyers in Georgia, it correlates 97% with the number of people who died by becoming tangled in their bed sheets. And you can see it's about 900 people a year in the United States. So if you believed in the power of correlation, you would say that if we would just close those law schools in Georgia, eventually we would have less lawyers in Georgia and less people would die of getting tangled in their bed sheets. Of course, that's a spurious correlation since I got it from that website. I use this to kind of make the point that we see a lot of autoimmune diseases in young adult and adolescent women. So you will certainly get on the internet and find dozens of women who had lupus, who had Guillain-Barré syndrome, who had new onset seizures, who had new onset asthma in their teen years and can be temporarily related to the HPV vaccine. But based on all the studies we're going to talk about in the next few slides, they're not correlated. Those rates of diseases are high in both the vaccinated and unvaccinated groups of women in that age group. So we have less data on men because vaccinating men is a little newer phenomenon, but eventually we will have that data as well. And so here are some of those, a review of some of those studies. Again, there's a huge safety review of 109 studies with 2.5 million subjects that showed no link to autoimmune or neurological diseases. And so this is a systematic review, and that's the highest level of evidence that we have. So, and then this guy at the Science March from a few years ago says, what do we want evidence-based medicine? When do we want it after peer review? The residents always show this whenever I'm in clinic or staffing labor and delivery, because I'm a big stickler for that type of thing. So the 9-valent vaccine was the initial safety data from the American study. Pardon me. With the warm weather here, we're having some allergies, so my voice is getting a little hoarse. So the 9-valent vaccine safety was reviewed at a recent ACIP meeting. I think it was last fall of 2018, October 2018. There's a YouTube video of that if you would like to look at it. It's not quite been published yet because it is very new data, but again, I hope that that will be the lead story on the news when that data does get published. So the main side effects, and these are pretty predictable, are site reactions and syncope. Adolescents will faint with any needle, if it's a flu vaccine or a meningococcal vaccine, and so that's just a common side effect to this age group. Site reactions are probably a little more common with this vaccine. It does have a fair amount of adjuvant and protein in it both, so you can expect to have a sore arm from this vaccine. But those are the main things, and these more serious side effects have not been correlated with the vaccine. So how are we doing? Well, we had these other two vaccines that were came out about the same time. The pertussis booster, which is Tdap, and the meningococcal, the quadrivalent meningococcal vaccine in 2006. And then the next year was the HPV vaccine. And so that's the yellowish line for females initiating the vaccine. And so you can see the gray and black lines here are increasing, but the yellowish line is not keeping up. So, you know, all three of these vaccines came at this same time, and keeping with what Senator Kennedy said, you know, we ought to be able to get up to 80% here, and we're not there. In about this year, we realized things were plateauing, and so a lot of this research I'm going to talk about as far as implementation, you know, is data about how to bend this curve upward. And so the male line on here is this kind of light grayish line, and so that was a newer recommendation in 2011, and so you can see we've almost caught the males up with the females. So these data are published every August in the MMWR. This is the 2017 publication, I thought was a little clearer as far as the different vaccines. The slide I'm going to show you next is the 2018 data. So I guess it still makes sense. So the solid line is Tdap, and then the HPV vaccinations are these lower lines, unfortunately. And so this is women here. Oh no, this isn't broken out by gender, I'm sorry. This is HPV vaccine up to date here, and so you can see it's lagging behind quite a bit. So this next slide is state by state. This is actually from a quality assurance project that Blue Cross and Blue Shield did. It's available on their website. I actually pulled this off of Twitter when I saw it a few years ago. The president's cancer panel has somewhat similar data. So does Kaiser Foundation. And so I just thought this was nice because it shows some of the states that have the lowest rates, and unfortunately they are the states that are surrounding me. I could walk to Missouri from my current location, and Missouri and Kansas are both not doing very well. I'm going to go give grand rounds for one of our former residents who's in Oklahoma City here in a few months, and as you can see, they are not doing so well either. However, one of these states, here it is, North Dakota is one of the better states. So I'm not sure that North Dakota is that much different, and Nebraska, that much different than these other states. So obviously something's going on that's not just a flyover state phenomenon. So some states are doing well, and if you're in one of those states and you would tell us what you're doing well during the question and answer, that would be wonderful. I've been trying to get some information from North Dakota and Nebraska and see what they're doing. And so we're going to talk about evidence again, and the best evidence, and there's a British systematic review here that I'm referencing about ways to increase HPV vaccination rate, is a clear and consistent provider recommendation. So I think you need the HPV vaccine today to prevent cancer. So other effective measures that you can do is remind and recall. Of course, that has more to do with the second and third dose, if you're trying to complete the series. So you send the patient a text or a email or a letter telling them that you have you're due for your HPV vaccination in 3 weeks, please call our office. Patient education actually has been shown to increase the uptake of this. There's some exciting new data, and some of this has not been published either, that videos are a good way to communicate that data, and so hopefully that will be published soon. And so people, of course, in the digital generation relate more to quick videos than they do to pamphlets. So another way to do this is to give for bosses, for managers, to give clear assessments to people. One of the examples that was given was posting all the providers in the clinic, A through Z, and say, as you can see, Dr. All, you're C on this list, and your rate is much lower than all your peers. And that, a lot of people that have gone into healthcare are used to getting straight A's, so that makes us competitive, and that actually works. So there have been a fair number of studies where they've tried all these things at one time, and so I call that multi-component, but you might call that a shotgun approach, but it works. They seem to be synergistic, so that's the good news. So mandates have not really been shown to be effective. We only have 2 states currently, although I know there are some other states that are considering it, including the state of Kansas, mandates to increase vaccination. So that the 2 states that have done it really have not found outstanding results. School-based vaccination is what happens every place else in the world except for the United States, at least all the other English-speaking and Western nations, but there's not enough data to know whether that really works in the United States. And then provider only, any of you that have electronic medical records probably have pop-up menus. We have one for pertussis boosters during pregnancy, and so we get that pop-up all the time, and that has not really been shown to be effective, although we did show it to be effective for our local pertussis boosters. So this is exciting data. This is from the University of North Carolina. This is part of the HPV roundtable that some of you may have heard of, but basically they went to pediatric practices and family medicine practices in central North Carolina and either trained them in what they called announcement style recommendations or conversation training. So the conversation training was kind of the control, and so they had the provider start a conversation about the 3 adolescent vaccines, ease any concerns, then recommend the HPV vaccine and provide it. And then for the announcement, they just came in and said, you're due for meningitis, you're due for HPV, and you're due for Tdap today, and then recommend that they get the vaccine. And if there were questions, that you can see that if needed is not very bolded here, they would go down here and that. And so depending on how you kind of slice this, the announcement was always better, a 10 to 16% increase in first dose coverage in the announcement group. And so there have been some other data like this, basically over explaining the HPV vaccine and somehow making it different than some of the other routinely recommended vaccines in this age group. And so you should still have the knowledge to answer questions, and I suppose that's why a lot of you joined us today, but it's best to start with the announcement style. And so that kind of is summarized here. So weaknesses as far as people that have low uptake rates are people that use risk-based strategies, trying to guess who's going to get exposed to HPV and cancer in the future. Of course, that's very difficult to do at age 11. A lack of urgency. You can get your meningococcal vaccine today, but let's talk about the other later. So about 90% of adolescents that are unvaccinated have had visits for the other adolescent vaccines where they could have gotten the HPV vaccine. This data is a little older, but there's a weaker recommendation for males also has been shown to be a weak way to raise your vaccination rates. And the best way to do it is to, again, the announcement style your child is due for these adolescent vaccinations, to make a strong recommendation, to emphasize cancer has been shown, and then to elicit questions. Again, I think most of you will be able to answer the most common questions after you finish this webinar here in a few slides. There has been some data about secondary acceptance. In other words, if they say no when they're 11, do they get it before they age out of the vaccines for children? And this was just published about this time last year. I hadn't really thought about this since I don't do pediatric and adolescent care, but basically if you ask again, about half of the parents are going to say yes after age 11. And again, acceptance is associated with provider recommendation and further information about the HPV vaccine. The same thing I told you a couple of slides ago, but only about half of us report further discussion. And so that's probably something that we could do a lot better on. So my last couple of slides here, I'm going to talk about the expanded age range. And so why are we talking about this as a national policy? Well, there's a little bit of data that says, again, this was a clinical trial that we did at Iowa, that it's an effective intervention. So we can show that 83 to 94% of the time we can prevent cervical dysplasia for the targeted types. This is based on the quadrivalent vaccine in women 27 to 45. Women who continue to age into what has been called the mid-adult cohort and continue to have sex are still at risk for HPV infections of their cervix, as well as cervical dysplasia and that type of thing. We don't quit screening women at age 30 just because they've aged into that. So there are rising rates of HPV-related head and neck cancers, which I've said several times, and this is very expensive. So even a little dent, and I've said that several slides ago, even a little dent in the abnormal pap smear rate would be a tremendous cost savings. So that's the reason that this has kind of come up. The effective arguments against the expanded age range are really new HPV infections happen in the already targeted age range in late adolescence and early 20s. There are still new HPV infections as you age, they're just less common. So it's unlikely to be cost effective to vaccinate everybody up to age 45, men and women, but if you look at the discussion, again, it's on YouTube if you are so inclined. The ACIP meeting gets on YouTube before the notes get summarized, so that's, if you want to catch up, that's a good way to know that. And the other thing is, are we putting the cart before the horse? Should we really be concentrating on doing better in the 11-year-olds rather than vaccinating the 40-year-olds? So those are kind of the arguments against, I think. So let's do some conclusions here. So there are many HPV-related cancers. I probably talked about 6 or so, and several of them are on the rise. Really, almost all of them are on the rise. It's just cervical cancer that has been drifting down because we have secondary prevention for cervical cancer. So the newest version of the HPV vaccine could prevent 90% of cervical cancers, and that's a global figure. So, one of the leading cancer killers of women in the developing world, it's usually either first or second behind breast cancer. We have a vaccine for this. So this is a very exciting story for women worldwide. Australia has made it a national goal to wipe out cervical cancer in the next couple of decades on their continent. So provider recommendations are the best predictor of HPV vaccine uptake, really of all vaccines. So I hope I've given you plenty of ammunition to talk to your clients about this. So as I said, future developments are emphasis on males. We talked a lot about expanding the age range at the February 2009 meeting of the ACIP, or I'm sorry, February 2019 meeting of the ACIP. And so you can look at that on YouTube. There may be a vote at the June meeting, but certainly throughout 19, we're going to be talking about this at the ACIP meeting. And again, you can tune on not live. You can look at the slides for the presentations. You can find the CDC's YouTube channel with just a quick Google search. So I think we have time for 10 minutes or so for some questions. This is my email address. This is my Twitter feed. If you follow me on Twitter, you'll find out pretty quickly that March is basketball season for me. It's my personal Twitter feed, although maybe a third or half of it's business, not all of it's business. So, oh, and this is the JDoc. So this is no longer an official emblem of the University of Kansas, but you may recognize several decades ago, an alumni of the medical school dressed up a doctor, or dressed up a Jayhawk as a doctor. So that's my usual ending slide. I meant to put a slide of my daughter in the NICU at the University of Iowa in there, but I ran out of time. So I'll be glad to answer some questions. And I, through the miracle of electronics, have a chat box, but I don't know if we can ask questions in real time or not via the internet.
This is Layla again, and yes, if you have a question, you can actually put it in the question box or the chat. I'm not sure if you're able to type in the chat, but you certainly may put the question in the question box. Dr. Alt, if you can see the questions there, I can read them to you. It's up, it would be.
Looks like I should be able to see them, but I don't see any popping up. Do you see any popping up?
No, but we'll give them a couple of minutes.
Okay.
If anybody has any questions, please. I see.
Maybe I could fill in a minute here to say a little bit more about the ACIP since I'm a new member. So there are 15 voting members of the Advisory Committee on Immunization Practices. One of the reasons that committee is particularly important is it controls the funds for vaccines for children. And so we do vote. And so we also vote on adult recommendations. And so there may be a vote on this expanded HPV vaccine in June. The agenda for the meeting will probably be published at the beginning of June. Your tax dollars pay for this activities of the CDC, so you can look in live, you can send in comments, so there's lots of ways to interact with this seemingly nebulous committee. So certainly stay tuned. And as I said, you can go back in your pajamas at night and watch the YouTube videos or download the slides. I don't think the slides from the February meeting are quite available yet.
It looks like we do have one question. How is HPV prevalence in the 14 to 19 range measured?
So the study that I showed you were actually self-collected vaginal swabs. And so the NHANES data, that's one of the activities the CDC does about every decade, goes out and basically does a history and physical on a bunch of people. I think it's about 10 or 15,000 Americans. It's the NHANES stands for the National Health and Nutrition Study, maybe. I'm not sure I've got the acronym quite right, but the data that I showed you were self-collected vaginal swabs for the 14 to 19-year-old women, and then the male data where I showed you the men and women from a little later were oral rinse and spit. I don't think all 15,000 people that were in that study did those, but a certain subset did that. So I think it was NHANES 3 versus NHANES 4 where the data I showed you, and NHANES 5 may be going on right now. But the NHANES data gives us statistics like, so many Americans have an elevated glycosylated hemoglobin indicating diabetes. So they make broad statements by those data sets, similar to what I did today.
Okay, there's another question. Do you recommend getting the 9-valent? Oops, it just disappeared here.
After the quadrivalent?
So. Oh, there you go. Yes, yeah. Do you recommend getting the 9-valent?
That gets asked every time I give a talk. So there's not a recommendation really from the ACIP or anyone else that I'm aware of to do that. And so the advantages of that is you should be able to get the extra benefit from the extra 5 types. And there is a study that shows that that's safe and effective to do that way. Again, there's pluses and minuses to these kind of clinical recommendation. The minus would be the quadrivalent vaccine has done a pretty darn good job of preventing disease. And based on that Scandinavian Danish study that I showed you, that protection lasts at least a decade. So it's going to be hard to improve on that. So I think that's really kind of an open question. You could certainly probably find a payer that would do it up to age 26. Beyond that, I think it's going to be tough, at least until we start tackling these questions at the ACIP.
And then there's one that says, do you have suggestions for bringing this up to a young man in a family planning clinic for STD testing, especially oral cancer? They don't believe they can get anything.
So oral cancer is common enough that I would guess that that you could probably find relatives in a family. The other thing that I've noticed about that community, and if anybody is listening here in Kansas City, you probably know this guy because he does the Chiefs Talk on the CBS affiliate on Monday mornings after the Chiefs games in the fall. His name is Neil Jones. So he had an HPV positive head and neck cancer. He's probably about my age, so mid-50s, which is treated at KU, is likely cured, but has daughters even a little bit younger than my daughters. So he has really been on a mission to go out and talk about this. So, you know, again, if you have a video or you can somehow emphasize a story, you know, that's a good way to emphasize that. So there aren't, you know, there's certainly data that the more sexual partners you have, including oral sex partners, put you at risk for oral cancer. But yes, that's something that happens much later in their life. If you're a adolescent male, we're talking, you know, the peak age for these cancers are in their 40s, and so we don't have that long tradition like the pap smear to fall back on in the males.
Let's see, another one. My previous employer was a pediatric clinic. Often parents like to wait for the next annual visit to get the second shot in the series. Is there any research that indicates any changes in the efficacy?
So the data is really about the immunology. The efficacy data is going to come later because it takes a long time for these precancers and cancers to develop. If you're going to do the 2-shot series, you can do them 6 to 12 months apart. And so, you know, I'm speaking for our own pediatricians here to a certain extent, but they were really excited when that 2-dose regimen came out, because they said, okay, we'll give the first dose on the 7th grade physical, and we'll give the second dose on the 8th grade physical, and then if they drift away in later high school and college, we've got them covered with the 2 doses. So yes, they can be given a year apart. And I know a lot of people had adopted that already with the quadrivalent vaccine. And there are some data that's immunogenic, even given that far apart. It's a very immunogenic vaccine.
Are there any other questions? If you have any other questions, go ahead and type them in the question box now. If you think of anything after after we get off the webinar, feel free to either email them to me and I can forward them on to Dr. Alt, or I think he's got his email there. You can probably reach him directly.
You can put them on Twitter as well. I will probably not get to Twitter or email until later in the day. You know, there has been a lot of, I'll just finish up with this thought, there's been a lot about social media and anti-vaccine forces in the last few weeks or months in the national news because of the measles outbreak. My wife told me that Madam Secretary, actually, that TV series actually tackled that topic on their last show. So if you put that on Twitter, you know, just try to let some stuff roll off your back. Somebody got on my Twitter feed this week and said, if I'm doing so poorly in my departmental NCAA pool, why am I giving advice about vaccines to my patients? So it's not always logical what you get back. So as far as feedback, but I think, you know, we have the facts about this vaccine, specifically the safety and efficacy of it, based on a good decade of research.
Thank you very much, Dr. Alt, and this concludes the webinar. Thank you, everybody, for participating. I will be sending out an evaluation by email, and I hope you will all fill it out and send it back. Thank you. Are you still there?
I'm still here.
Okay, yeah, I think that went very well.
Yeah, I've updated it a little bit, so, and took some things